how do I, this timer here, am I responsible for starting it, or?
What's that?
The timer here, do I start that? Oh, okay. All right. Jason introduced me. I'm Raven Travillian. I'll tell you a little bit about myself when we get into the story of how I ended up working at Harborview Refugee Clinic. So what I'm going to talk about today is stories from the clinic. What I wish I had known about pain science when I started out. So the Mosley Challenge, you'll remember that from our first day. He asked us to think about how we could prove ourselves wrong. So today I'm going to share with you some ways in which I've reflected on that, how I've proved myself wrong in retrospect, going back and looking at what I encountered in the clinic, what I wish I had known, what I'm going to do better from this point out because I have a different understanding than when it happened. I'm doing this by rethinking some of my earliest cases. So I want to get at the question, how could I have done better by my clients if I had known then what I now know? And how can I take this going forward? How can I better serve my clients from here on out? So John Ware and Jason Silvernail also touched on themes I think that are very important to this topic. We have to recognize when there are comorbidities, when there are conditions existing alongside pain, and that they impact a way that exceeds the practitioner's ability to deal with them. We have to know when to recognize things. We have to know when to refer out. We have to take responsibility. I'm going to talk about the education that led me to this point. I think our education for massage therapists in the U.S. needs to do a much better job of teaching us to assume responsibility. And I'm going to be making some speculations during this presentation about what I thought was happening at the time, what I think now in light of better knowledge might be happening, but I want to be very clear. I wouldn't share these speculations with the client because that's not my job as the massage therapist. This is based on the things that I've discussed with the other members of the healthcare team. This is what we think is going on. I don't diagnose, I don't interpret, I listen to what the client tells me. This is just based on the team discussion behind closed doors. Okay, so as Jason asked, I'm going to tell you a little bit about myself. And I've taken a very circuitous route to get where I am. I was an undergrad humanities student, so I did my bachelor's degree in Alabama in French and German. And then I wanted to do something different when I got out of Alabama, so I studied Cambodian and Southeast Asian studies at the University of Michigan. I left Michigan because I couldn't take the winters, and I headed out to Seattle. And I found there that a degree in French and German and a master's degree in Cambodian studies plus $2 would get me a latte. And so I went to work in the software industry. And actually, I was lucky. I came along at a really auspicious time because Microsoft was hiring people with foreign language skills. I didn't have to have technical skills back in the day to get hired at Microsoft. However, nowadays they don't do that. Nowadays they expect you to come ready to hit the ground running. But in those days they were training. So I had the benefit of learning a lot of technical skills. I did not get in on the stock options, but I think that what I got might even have been worth more than that. But all good things must come to an end, and I got bored with what I was doing. I hit as high as I was going to go at Microsoft. So I started looking around for other things to do. 2 people on my team were going to massage school, and I thought, that sounds awesome. I had never, ever thought of such a possibility. So I began studying at what was then Brennecke School of Massage, and I had a friend from my old days back in Cambodian school who was working at Harborview Refugee Clinic. He was a Hmong interpreter. The Hmong are a hill tribe from Laos. If you've read The Spirit Catches You and You Fall Down, that's the group of people that are talked about in that book. So he asked me if I'd be interested in doing massage at Harborview Refugee Clinic. And I was like, sure, this sounds like a wonderful opportunity. Please do hook me up with him. So I worked there for 7 years. I then went into private practice. Later I went back and I got my PhD in biomedical and health informatics. Informatics is information science. How do we receive information? How do we categorize information? How do we organize it in our heads to make sense of it? How do we share it with other people? So we've talked a lot about meaning today. We're going to get back to meaning over and over again. And my dissertation was on the semantics of anatomy. When we're talking about cancer in a model organism, how do we know that that knowledge translates into cancer in humans? We can't experiment on humans. It's not ethical. We do consider it ethical to experiment on rats, but rats are very different from humans. Metastasis from prostate cancer in humans travels up the spinal column into the brain. In rats, it often travels into the femur. So something's different going on anatomically and physiologically. What do we make of those distinctions? What do they mean? How can we use imperfect knowledge to make sense of things across species? So the emphasis on meaning that was talked about over the last 2 days fits in very nicely to what I do. My dissertation was to make a computer model of some anatomical structures that the Mouse Models of Human Cancer Consortium were particularly interested in. So I took the job working at Harborview, and my clients, for the most part, I started out working with refugees from a variety of different places around the world: Southeast Asia, the Middle East, East Africa. What they had in common was the experience of being displaced, of seeing really horrible things, of ending up in a society that they had not been prepared for. They came here, they're starting all over again at zero. I later branched out. I began working with veterans. Veterans coming from our larger society don't have all the disadvantages that refugees do, but they do share in common a few things as well. They've also seen horrible things. They have more social support structures in the military because the military understands that it's sending young men and young women into horrible situations, and it tries to prepare them for that. So there's similarities and there's differences between the experience of being a refugee in combat and being a veteran in combat. I've also worked, not as much, with people with high-risk pregnancies. So monoamniotic twins is considered a high-risk pregnancy. If the two twins share a sac, it can be really, really problematic when it comes time to emerge. So monoamniotic twins is a high-risk pregnancy I've worked with. Anything above 2 is considered high risk. Even a normal triplet pregnancy is just classified as high risk. So I've worked with people with triplets. I work with stroke survivors, and I have a young man who came all the way from Central Asia for a massive reconstructive facial surgery. If we have time, I'll tell you about his story. So Harborview Medical Center has a large facility. It's the #1 trauma center in the Pacific Northwest, and it also does a lot of community medicine. They have something which was called Refugee Clinic when I worked there. Now they call it International Medicine. I mentioned the refugees who come there for treatment, they get a full range of treatment, everything from family medicine to referrals to specialists to massage. They provide acupuncture. What they care about, they care about providing culturally appropriate care to the people who come there. And most of the people who come there are of lower socioeconomic status, so it's funded by Medicaid and by other programs and by grants. So sometimes I was paid when we had a grant. Sometimes I wasn't paid. That was cool. I still enjoyed working there. I wasn't there for the money. Yesterday when John was talking about Motivation 1.0, I was like, yeah, that sums it up perfectly. I like that. What we see a lot, we see comorbidities along with the pain. We see a lot of depression and a lot of anxiety, and that totally makes sense. People were raised for a very different life than they find themselves in now. So they've lost everything. A lot of them are still grieving. A lot of them never have gotten the chance to get past that because they're so busy surviving, they can't think about, okay, how do I thrive? Not just survive, but thrive. So they also come from societies where talking about feelings is deprecated. The idea of lying on a couch and talking to someone about your feelings is a very Viennese, very Western European idea. And a lot of cultures, not only would it never occur to them to do that, but it's actually, you're talking about your feelings? That's kind of self-indulgent. Get back to work. So, you know, the people who come here, they have a lot to cope with, but they don't have the same ways of coping with it that Americans do, and a lot of their ways aren't functional in our society. So it's a very complex problem. It's pain, but it's a lot more than pain. On the other hand, because they're not supported in talking about their feelings, there's a lot of translation into physical symptoms. I would say that 95% of the people who I worked with at clinic had one of 3 complaints: headache, backache, stomach ache. Because these are culturally appropriate ways of being sick in the societies they came from. Everyone understands that. I found Kara's concept of levels to be extremely useful. This was a new idea for me when she introduced it on the first day, but it was perfect. Classifying people by the level at which they were able to function in the society around them. A lot of the refugees are at level 3, not because they don't want to work, not because they don't care about being productive members of society, but they don't have the tools. I had one man who, back in his home, he was a teacher of classical Cambodian literature. What's the market for that in America? Nobody wants to learn. Even a lot of the young Cambodians don't want to learn it because they're into the American culture. So he went from being a respected, venerated member of the community to playing mahjong and watching TV in a language he didn't understand all day long. I mean, classic depression. So this is a lot of the people we're working with find themselves in situations like this. And literacy is not as high a rate as it is here in the States. So handing out information on paper is not always going to work. So we have to look at other ways to get information to people so that it's actually useful to them. So it's not something that just ends up in a drawer somewhere. So videos, television programs, the Information and Communication Technology for Development movement, the ones who are doing things like making appropriate technology, like so that people all around the world can read their language on mobile phones. There's a lot of interesting possibilities there, I think, for refugee information dissemination as well. So a typical session at the refugee clinic, there was a whole range. There was best case to worst case, depending on the resources we had at the time. So if everybody had time and there were enough interpreters that day, we'd have a really good session sitting on the floor. We'd all sit on the floor together. Everyone is at the same eye level. I'd be sitting behind the client, typically working on their back. Like I said, headache, backache, stomach ache were typically what people presented with in the clinic when they were referred for massage. The psychologist would sit on the floor with us so that everybody's at eye level. He's not having to look up at the doctor. And the interpreter would be sitting nearby, not in the line of sight, but close enough to catch all the nuances of the conversation and to interpret it back and forth. Those were the best sessions. More typically, however, I would come in and find out that we were short on interpreters that day. So as a massage therapist, I was last in the priorities for that, just because it makes sense. I mean, you can't have psychological talk therapy without an interpreter. And the nurses and the MDs are ordering lab tests, and they have to absolutely accurately communicate values. So I get why I was the last one in line, but it often means that I was handling the situation myself. I had studied Cambodian language, so it was kind of, it's okay to let Raven speak Cambodian, it's fine. But as you'll see, that didn't always work out the way it was planned. One time I went in there, and I was on my own, no interpreter, and the woman client was lying on the table, and she kept saying over and over again, "Knyom Chang Slap, I want to die." So I didn't know what to do about this. I'm not a native speaker of Cambodian. I don't know what this means. Does she literally mean I want to die? Is this an emergency? Do I need to go get help right now? Or alternatively, is she just doing like I do sometimes? I'm so tired I could just die. And then if I call down the entire mental health system on her, that has the potential to be a life-changing issue once the mental health system gets involved. I didn't receive enough education in massage school to understand at that point how ethics really work. I thought I had to know enough and make the decision on my own and decide what to do. I understand now how ethics work better than I did at the time. Ethics are so that you don't have to find yourself in the situation figuring out what to do. Ethics are so that you know what to do in a situation. You get help. I'm over my head. I'm overwhelmed. I'm going to get the psychologist and the MD right now because it's a possibility that this woman is a danger to herself, and we want to make sure that she's kept safe, that nothing bad happens to her. As it turned out, she was committed for 3 days. She actually was suicidal. Not having an interpreter, I felt myself shocked. I was going in there expecting to give a massage. Suddenly I'm trying to figure out, okay, how do I save this woman's life? I have to say, there were some really, really wonderful experiences at the clinic, and there were times when I look back and it scared the liver out of me. So it was very, very intense both directions, very good and sometimes very, very scary. Like I said, I found myself in the deep end. Massage school education in Washington, 500 hours is required. It's at the vocational technical level. And accreditation's optional. So there's no guarantee that the anatomy that we're being taught, or the physiology or the pathology that we're being taught, corresponds to what physicians, nurses, other healthcare professionals are being taught. Washington State tends to be pretty good about it, but the quality that varies all over the U.S. So the client cannot depend on finding a massage therapist and knowing that, okay, I can depend on you to have a specific baseline of education. I can count on it that you know this, that, and the other. It's a very, very big problem in the United States. For that reason, we have a very low position on the social hierarchy. Massage therapists are often not taken seriously in the U.S. And we need to change that. We need to work on changing that. And to do it, we need to step up and assume a certain degree of responsibility. Now, I will say that Harborview Medical Center Refugee Clinic was never like that. From day one, when I walked in through the door, I was a full member of the team. People came to me and seriously asked me, what do you think we should do with this client? So I think that serves as a model. I think the potential's there. We have allies. We just need to know how to strengthen our bridges to these allies, how to make the connections, and how to step up with the responsibilities in order to hold up our end of it. One of the clients brought this contrast very, very strongly to the front when I went in there, and she was in the fetal position on the table. And she just said, tell me what to do. I'm like, what? What? I'm not used to this. I'm used to being the massage therapist who asks, what are you looking for? How can I help you? She was treating me as the doctor in her society. Her society is very strictly hierarchical. Doctors are very privileged, very powerful, very strong. She doesn't really stand up very well against that hierarchy. And she's putting me in that position. As the massage therapist, I was the doctor in this situation as well. So it took quite a lot of adjustment for me to get used to some of it. The way that massage school taught me, the give and take, the freedom, you can't always assume that everyone else is coming out of the same background you are and has the same expectations. You have to come in there and be prepared to make them comfortable, even in light of very, very different expectations. Now, I don't think I handled this well. I think this is one of the times where, looking back, I proved myself wrong. I figured I only have her for this session. Okay, fine. She wants me to tell her what to do. I will tell her what to do because I don't have time to do anything different. Now, after the last couple of days, I've been thinking about some ways, how could I support her self-efficacy, even embryonically? Okay, I'm only going to see her this one time. I understand that. I don't have a lot of time to work with her on that. But what can I do in our 30-minute session together that doesn't reinforce this dominance hierarchy? So I proved myself wrong in that case. I would still try to offer her the locus of control. So there was another example where this was a session that was the best case scenario. The psychologist was there seated on the floor. The interpreter was there. I'm sure that all the interpretation was correct. I'm sure that I was not operating under I misheard a word in Cambodian or anything. We were sitting on the floor. I was working on the woman's back. And she was telling us why she had pain in her head, her neck, and her back. She had been in a car accident, she explained to us. And she had been, it was at a major Seattle intersection. I knew it well. So she was riding in the car. She was a passenger. She was not the driver. She got into a crash there. The people in the other car got decapitated. She saw their heads rolling through the intersection. I was astounded. How could such a thing happen? It's shocking. I went back and I looked in all the news reports. There was no such accident reported like that. I think something else was going on there. I didn't know what to make of it. I talked to the psychologist and to the interpreter. The interpreters act as culture brokers at Harborview. They don't only just translate the words back and forth. It's like, okay, tick-tock, we're done. What they try to do is they try to give you the background as well. In the context of the culture, what does it mean when somebody says something like this? So you don't just get the words. They try to provide the meaning as well. Here's the conclusion we came to, what I think is going on. Our best guess, she was an offender bender. She did get hurt. Her neck and her back really did hurt. The chief complaint she was presenting with were directly connected to the automobile accident. However, she was also remembering things she'd witnessed in California. If you've seen the film The Killing Fields, you know the kind of things that went on. I've had people tell me that they didn't like the movie, Cambodian people tell me they didn't like The Killing Fields because they thought it soft-pedaled it too much. So I think, the psychologist thinks, the interpreter thinks, she was thinking of something she saw in Cambodia. It had come up in the session with us because she felt safe. She's talking to a psychologist who's listening to her. The interpreter is making sure that her meaning is getting conveyed back and forth. I'm touching her in a way that's totally non-threatening and relaxing. In this situation, she's finally safe enough to talk about something that she actually witnessed in Cambodia, a really horrific scene that at the time she wasn't able to process or to talk about. I don't know. This is an interpretation. It may be right, it may be wrong. I don't know. But what I do want to know is there anything more that I should have said or done in this situation? I don't think so. I think what we did was all we could do. We created a safe environment. We reassured her that she was okay. I think this decision does stand up in light of what we've learned about pain science since then and what I've learned over the last couple of days in here, simply because things are going to emerge in a safe environment that we can't predict and that we have to be ready to feel, for the sake of our clients, we have to be ready to field them when they do come up. A lot of clients make meaning, but they make meaning in opposite ways. So if you drive through Seattle around August 4th, there's a big festival called Seafair. And you can see a lot of people, in Pioneer Square, there are a lot of homeless people living there. And the Blue Angels often come to Seattle and perform. So you can see people having bad reactions to that. You can see people for whom these fighter jets screaming overboard re-traumatize them. So, people will suddenly go into a freak out when the jets appear. So I was used to the idea that the Blue Angels, this precision flying team, is a traumatic experience for people who've been exposed to war and trauma. But I had another gentleman, a Vietnamese soldier, he's actually at the intersection of veteran and refugee, that I'll talk about a little bit later if we have time. For him, the Blue Angels was not the sound of trauma, horror, and death coming. It was the sound of the cavalry coming to his rescue. He was stranded on the battlefield. The jets meant that help was on the way. What I learned from this is, don't bring my pre-assumptions into there. I brought my pre-assumptions about the homeless people I had seen, and I was mistaken. I was 180 degrees wrong. From him, I learned that my job is to get out of the way of the client's own meaning making. It's the client's job to tell me what it means, and it's my job to listen without interfering or without projecting onto him what I think, or her what I think it means. I went the wrong way. Okay, so that's been some pretty heavy material. So let's cleanse the palate with a little success that I'm very pleased with. A lot of the clients come from cultures where they're very, very modest. They don't want to undress in front of me. They're not going to undress in front of me. Some clients, they won't let me work on guys because you don't work across sexes that way. So I found that shiatsu was a big hit in the clinic. Shiatsu fit what people were looking for in a lot of ways. It was similar to what massage is conceived of in their culture. They don't want to undress. They can sit in the chair. They can keep their clothes on. They're very modest. They're very comfortable with that. My learning shiatsu conveyed a message to them. I care about you. I want to learn what you expect. I'm willing to invest the time and the effort to learn what it is you expect and to meet you where you are. I learned I could do that, and I don't have to buy into the mechanisms behind it, which I don't believe in, having been trained as a scientist along the way. I can't buy into the energy theories behind shiatsu, but that's okay, I don't have to. As we've talked about in the conference, we can retrofit a lot of the techniques and the techniques still work. If we let go of implausible explanations, we can still keep the benefits that the techniques provided. We can have the best of both worlds. I found this in the clinic in providing shiatsu, and I'm very pleased with that. I think it worked out to be quite consistent with what I've learned explicitly from the speakers over the last couple of days. Another gentleman who, well, I won't tell the ending. I won't give away the spoilers, not yet. So his complaint was half of his body was missing. He had been an East African soldier. When Eritrea and Ethiopia used to be one country, and Eritrea decided it didn't want to be part of Ethiopia anymore and broke off, this man was in the Ethiopian army. He was fighting to keep them together. Eritrea won and Ethiopia lost. A couple of years later, he was in the clinic, sitting on the table in front of me, telling me that half of his body was missing, just like I would tell him, okay, I had a bagel and cream cheese for breakfast. That calmly, that matter-of-factly. So he was absolutely unconvinced. They had tried everything. They'd given him physical exams. They had taken images that held up, you see this x-ray? There's your arm, okay? None of this was working. He was just totally not having it, not at all. They referred him for massage because they thought that maybe we could use the sense of touch to reassure him that half of his body was still there. We failed. Massage didn't convince him any more than the images convinced him or than the physical exams convinced him. He went away. I don't know what happened to him. He was lost to follow-up, as they say in the jargon. I don't know what happened. The MD and the psychologist conclude it's conversion disorder. I don't know what I could have done differently in this case. I'm really interested if anybody has any ideas. I have talked about this with other people. Diane has suggested that maybe we overlooked an organic disorder prematurely. Because we're looking at it through a psychologist lens, the psychologist thinks it's conversion disorder, which is a psychological condition, but there are also organic brain conditions that can lead to it. I don't know. If he was looking at it as he failed to keep his country together, he lost part of himself. He was literally expressing what he felt about that. Maybe that's what's going on. Maybe not. I don't know. I do know that when if I am presented with a client like him again, I'm going to ask more questions. I'm going to see if I can get him to tell me more. I think I was a little passive in this. I would like to know more about what meaning he is experiencing. I don't know if there's anything I could have done differently to help him succeed. It may have been intractable, but I do think I should have asked more questions. I have another client. She taught me a lesson about ego. The next two cases actually are going to be like that. This woman was from the Muslim minority population of Cambodia. Every time she came for massage, she came back. She kept coming back. And she kept telling me, "You're giving me cancer." And so I was like, okay, why are you coming back? Clearly she was getting some benefit from the massage. But she was convinced there was cancer in her body, and I was breaking it loose, and it was traveling through her body waiting to get her. She'd been healthy. She'd been checked out. The psychologists were convinced it was survivor's guilt that was going on. She had witnessed some pretty awful things. Being Muslim in Cambodia is a minority within the larger population. So all the refugees had seen something awful. She'd seen things that were more awful than most. I thought, I'm going to fix this. So I went and did some research. I found in the Quran, I found a bilingual copy of the Quran where it has a verse about massage. And it says something like, allow them to treat you skillfully with rubbing and herbs. So I thought, well, if I show her this, it's permission. She gets to have permission for massage. She will stop worrying about me giving her cancer. I took the Quran to our session. I showed her the verse. She grabbed it excitedly and began reading. I was very, very happy. I thought we'd made a breakthrough, and I never saw her again after that session. So this was a lesson to me. It didn't matter what I intended to do. What mattered was what it meant to her. And I don't know what that was. I was in over my head. I should have gone more slowly. I should have consulted with the other members of the team more. We did consult. I didn't just do this totally freelancing, but I did talk with the psychologist. The psychologist thought it would be good too, but I think we should have been more conservative, more careful about it. A similar experience happened when I was reading a story from a children's book in Cambodia to an elderly lady. The message I wanted to convey was, I respect you so much that I'm taking the trouble to learn your culture and your language. She burst into tears. In Cambodia, women are not educated to the degree that guys are. Women usually get a rudimentary education. Guys are the ones who go on and finish elementary or junior high school and then start to work. Even this rudimentary education had been interrupted by the Khmer Rouge. So what I saw was, I respect you and appreciate you, and I'm making an effort. What she saw was, this foreigner can read my language and I can't. So, another misfire. What these two cases together taught me was, and it refers to what we've been talking about the last couple of days, it's not about me, it's not about me, and it's not about me. I let my ego get in the way, and it led to some outcomes that were unfortunate. If I had known more about what we talked about the first couple of days, I would have approached these women very, very differently. I would have tried to communicate the same things I wanted to communicate, but I wouldn't have done it as ham-handedly as I did. So I've learned from this. House was right, everybody lies. But the thing is, lies aren't always intentional. Sometimes people don't know that they're lying. Sometimes people are lying to themselves, and probably the word lie is not the right word in this case. I think lie conveys the intention to deceive. A lot of people don't have the intention to deceive, but they don't know what's going on under their own surface. And so, how can we know? America's a weird country. We're Western, educated, industrialized, rich, and we have a political democracy. We can't share the assumptions that everybody is coming from the same starting points we are. And in the clinic, a lot of that shows up because our interactions are so intimate. A lot of things that you never would expect emerge in the interaction in the clinic. And so not only do we have, we know every individual is different. That's duh. But there's a lot of systematic differences as well. My barging in to try to solve a problem was a very American behavior. I learned in my interactions that not only does this not work, it also backfires a lot. One of the things that the clients taught me also is you can't separate pain from anxiety and depression. As we were talking about before, a lot of the clients have low socioeconomic prospects or low socioeconomic status, and they don't really have any prospects. Sometimes all we were able to do was provide a safe place where for an hour or for 30 minutes, they didn't have to think about going back to what would be a dismal situation awaiting for them. And sometimes that proved to be very, very okay. Sometimes I learned that my treatment goals are what matters. If it's enough for the client to get away from having to think about reality for half an hour, that's often a good thing, and that's enough. What we say is not always what they hear. So one of the things that occurred to me as we were talking this, I learned some wonderful ideas over the last 2 days of this conference. I don't know yet how this translates into talking to my clients about them. Deborah Feldman Stewart is an informatician, and she's looked at a lot of situations, but the study I'm thinking about specifically is men with prostate cancer. When they go to the doctor and they get the news, at the time you most need to hear important information, the whole situation kind of makes you shut down. You're less receptive to information. Being in a doctor's office, it's kind of the white coat effect, like for blood pressure. So you need to get the information at the time when you're the least inclined to receive it well. So this is a problem. It means that we have to take more responsibility in how we deliver information so that it doesn't just wash over people's heads at a time when they're not receptive to it, so that they can really take it, integrate it, and incorporate it. But a lot of this is situational. We can take advantage of situational strengths to make the information come across more clearly, as well as the weaknesses that we know about, like being in the doctor's office. One of the important things is, in my practice, pain as an output of the brain is going to be heard as, it's all in your head. And that's going to be transformed into, therefore, it is not real. I still don't know what is the best way with my clientele to translate that message. I see a lot of possibility, I see a lot of reason for hope, but I don't yet know how it's going to work. So that's something I'm going to take away from this conference. I'm going to think about, I'm going to try to put into practice. I think it's really important. It really is important because it conveys hope and optimism, but how we do it, that's not immediately clear to me for the clientele I work with right now. Somatization is a four-letter word in some circles for that very reason. People hear it as, you're malingering, it's not real. So the idea that you can't talk about your emotions, therefore you express it in the form of backache or headache or stomach ache, it's really insulting to some people who think you're telling them it's not real. The Khmer word for depression, one of the Khmer words for depression, kutcharan pek, think too much. That kind of shows how people see it. It's like, if things are in your head, it can be a bad thing. Thinking too much is depression. So what I'm taking from this is, I'm not thinking don't pursue it. There's too much important here. It needs to be pursued. It needs to be put into practice, but in effective ways. I don't yet know exactly what those ways are. What I'm going to take away from this conference is, I have some things that I need to think about. How am I going to lay these out for my clients? How am I going to check in with my clients about what they want to hear? How, together, are we going to implement these effectively? I really like the idea of narrative-centered therapy that was in Corey's talk. I think there's a real opportunity for this. A lot of people from traditional communities share information through stories. It's a very, very natural way, very effective way. It's a way people are used to and that they will welcome. I think there's a lot of opportunity there to meet them where they're at through narrative-centered therapy and to promote them making the connections themselves. I don't have to go in and fix it for them. I can support them in making the connections, and it's going to be more real and more sustainable for having done so. Veterans, similarly, as we said, the cultures are not identical, but they do share some overlap. In America, fewer than 1% of Americans serve in the military. It really is a distinct subculture, and it's a subculture that most Americans don't know very much about. We just don't interact with veterans in our day-to-day lives very much. But there's a quiet emergency going on right now. We potentially have a lot to offer them, but we're not doing it yet. 2265 is a number that you'll see a lot. Every 65 minutes, a veteran kills him, herself, or herself. So that's a little bit over an hour. So in a 24-hour day, that's about 22 veterans who kill themselves every day. People come to us for help. We can be a sentinel. If we know what to look for, if we know how to be supportive, if we know how pain and the other comorbidities that they're dealing with in their everyday lives are playing out, we can't solve it for them, but we can be trained to be a nexus for resources, for helping people to find what they need. So getting veterans the help that they need via coming and looking for massage therapy for musculoskeletal issues or PTSD is a big priority of mine. And one of the things we're dealing with them is, just like the refugee cultures, the traditional cultures where you don't talk about emotion, suck it up and drive on is a military saying. The idea is we can't afford to have you indulging your feelings in a combat situation because too many people are depending on you. We need you to function. If you need to process something, save it for later. So in some ways, there's a lot of the same. We're not encouraging you to talk about your feelings. Barrett talked about the no pain that people experience in combat. On the way driving down here, I heard an NPR story about that, how a medic came under fire himself and was shot, but he kept on helping other people. He was treating them. He didn't realize he himself was wounded until all the others had been taken care of. And then Barrett gave me that reference to Anzio Beach. It's like, okay, good. I thought that this might come up at the conference. It ties it all together. It's very important to know these things about the clients we're dealing with because it reinforces the message that we were talking about the first couple of days. It is in the brain, so there is opportunity to interrupt and address it. This is very important and very full of hope. I have a Korean War vet he's widowed, he lives in a long-term care facility. He has pain from an airplane crash. He was an aviator in the Korean War, so his pain is officially older than I am. And I am really looking forward to getting back. When I drive back, in fact, I'm thinking of driving back into Seattle from the east side so that I can stop at his nursing home even before I get home and try out what I saw Corey do yesterday. I'm really excited about trying this and seeing if it's helpful for him. But I've tried working lightly with him. I've tried introducing the ideas that we've talked about. He's not having it. I have to work deep with him. He's very much no pain, no gain. And he's 85 years old, so he knows what he's talking about. He's been around a lot longer than I have, and there's only one way to address it. I can afford to do that. As Diane pointed out, it's about him, it's not about me. He wants to work this way. I'm in a position where I can deliver. I don't think it's really doing what he thinks it's doing, but that's okay. It's his time, it's about him, and I'm going to see if I can, instead of the frontal way that I tried it before, I'm going to see if I can incorporate some ways of encouraging him to open up to other opportunities about how to think about it and see if there's anything there. That's why I'm so excited about trying out what I saw Corey do. So incremental wins are a lot of what my practice is about. I don't get people cured. I don't do that. I often don't even deliver permanent fixes. A lot of what people do when they come to me, they're having trouble sleeping. So it's like, okay, you're not sleeping at all during the week. If we can get you 3 or 4 good nights of sleep a week, that's a gain. It's not ideal, it's not perfect, it's not what we'd like, but it's better than the situation was before. So a lot of what we're dealing with is the gains are in the increments, and I think there's a lot of opportunity where we can improve on that. I don't think I have time to tell you about my medical student because we're running low on time, but maybe the next time, maybe next Pain Summit. Okay, so I'm also sorry that I ran low on time because I wanted to tell the story of how I massaged a monkey. But I'll have to save that for another time. Very, very briefly, this was a sea monk, so she's actually a lesser ape. She's not a monkey, but it's funnier to say monkey. So the statute of limitations is probably over on this. I was a volunteer at the zoo. It's probably okay to tell the story now. The zoo's not going to come after me. Cleaning up the monkey house, I wasn't supposed to interact with any of the animals. However, she kept presenting to me. She wanted me to rub her back. When I rubbed it, I felt something like matchsticks. It was her contraceptive implant. She wasn't supposed to be breeding. The species survival plan is very clear on who can breed, when, and where. And since they hadn't got the memo, they had given her a contraceptive device to make sure. So it was causing her distress. She was presenting it, and I massaged it for her. So that was my opportunity. I thought of Diane when she was talking about the critter brain. I remember my experience in interspecies massage and how a lot of it was, except for the words used, because we did not use words, except for that, a lot of it was like our interactions with our human clients. You make it clear what the person being groomed wants, and they can tell you if they like it or not. So, critter brain for Diane Jacobs. For what I've learned from my experience in the clinic is we have a lot of work to do as massage therapists in developing our professional identity. And we've got some foundations for bridges already in place. What is it? Is it 17 disciplines being represented here? Something like that, 13, 17? Close, yes. So it's like we have allies in a lot of different fields who want us to succeed. We need to work on promoting those alliances. We have a model for multidisciplinary teamwork, not only in the refugee clinic, but also in programs like what Brent Jackson is doing in South Carolina. Massage programs are going into hospitals and going into clinics all over the country, and we need to talk about that and know more about that. We need support for clinical decision making, and tools like Joe's MIP looks very, very useful. That looks like the kind of thing that we need to be introducing in massage schools. I think the idea of clinical decision making is very, very much, I don't think it's taught at all, and I think we need to start chipping away with it with things that are user-friendly and easily understandable. We need to make use of these resources and ensure that they're connected to our evolving understanding in pain science. So, don't have time for more stories. I do want to say that I want to build on massage therapy's strength. Massage therapists are some of the best people I know. Some of them are fearless. Okay, I'm supposed to wind up. So they're fearless, they're compassionate, they're motivated. If we can take these strengths and give them the tools that they need, I think that we have the potential to make a real difference. So what I want to learn is involving the communities, meaning my research, and the acknowledgments. I want to thank people. I want to thank Rajam and the volunteers for bringing this together. It's looked effortless from our point of view, and when it looks effortless, that means that a lot of work is going on behind the scenes. So I especially want to thank them. All right, thank you. I have a lot of other people to thank, but I'll let you read that when I put the resources up.
So we're looking forward to for break, but let's take a few minutes for just a couple of questions here. So if you have a question, please put your hand up nice and high so I can. All right, we've got a couple up here in front. Let's start with Alice here. Alice, wait for the mic, please.
Yeah, I thought that was excellent. And the point about delivering the information in a manner that the client can receive, because we all treat so many different kinds of people, that really spoke to me. And you were talking about getting out of the way of the client's meaning making. And how do you reconcile that with, isn't pain education a manner of changing the meaning that they give to pain and their experience in their body and what they think about it and how they think about it?
That's a very good point. We all do have agendas, and my agenda is to communicate pain education, which means that I'm inherently promoting one idea and deprecating other ideas about it. So I think the idea is to minimize it as much as possible and keep it to communicating what's necessary. And the reason pain education is necessary, whereas my beliefs on Katy Perry's music are not necessary, is because we can align it through pain science to what's really going on in the universe, as opposed to arguing two conflicting subjective interpretations. I don't have the right to put my subjective interpretation on top of the patient's. But if the patient is less far away from the material, physical, natural universe, and I can help show a way back to that, I have a responsibility to offer it, and if the client rejects it, then I've done all I can, is how I see it. Did that answer your question? Okay.
Great talk. Being a body worker, I really appreciated that. How do you deal with other body workers that might be specializing in more of the woo, non-proven type of things, but we don't want to throw the baby out with the bathwater? They can still be helpful, but people that are so steeped in it, I find it very difficult sometimes to give them a little more of a rational, scientific version of what they're doing, of what might actually be going on. Do you have sort of a tactful way, if you're communicating with people that might be doing some of the the shiatsu and the Reiki masters and the energy work, where they're still getting a beneficial effect with their clients, but they're doing it under a sort of a dubious explanation?
I do, and sometimes I'm better at that than at other times. And what I try to do when I'm doing my best work is I try to stress our alliance in the interest of the client. And what do we have in common? We both want the client to get better. And like the Leonard Cohen song goes, I've been where you're hanging, I think I can see where you're pinned. I try and point out, it's like, look, if you follow energy biofields down that path, you're going to find yourself in a dead end. And that's not going to help be useful to the client. Sometimes I fail at delivering that message tactfully. And Sometimes people don't want to hear it. You can't reconcile, if your first principles, if the things that you don't rationalize, but the things that you count on at your core are fundamentally opposed to somebody else, you can't change that. But I find a lot of people aren't fundamentally opposed, they just haven't thought about it. And if you give them something to think about, and you emphasize what you have in common, often you can get a little movement.
More questions? Right over here, purple shirt.
What is it?
Hi there. I'm both a massage therapist and educator and also a registered nurse. And that has certainly opened doors a lot easier for me, adding massage into those areas and into those fields. If I'd walked in as a massage therapist, those doors would have been shut probably right in my face. But I had just a curious thing that you said right at the beginning, and I just wanted some input on that. We don't diagnose, and in my other profession I don't diagnose either, but you said something, we don't interpret. So could you elaborate a little bit more on that? Because I think we do have to interpret a lot.
Yes, I think you're right. I think I spoke a little bit too casually about that. We don't necessarily tell our clients 100% of our interpretation. We interpret to make meaning for ourselves in what we're going to do going forward. Some of that may be helpful to share with the client, and some of it may not. So it's a judgment call, and where we need to know more about clinical decision making is what kind of things, what kind of interpretations and messages is it helpful to share with the client versus what kind of things are not helpful or even harmful to share with the client. Absolutely, we have to interpret because that's how we make a plan to go forward. And thank you for pointing that out. I did slide a little bit too fast over that.
We have time for one more question. I think Leah had a question right here in the purple shirt.
I can ask her privately if needed.
Okay.
Oh, you got time.
Okay.
Last one.
This is in regards to your work with refugees and veterans. As someone who is a very veteran-based practice, I'm near several military installations. Do you find that you get the same level of loss, of that feeling of loss amongst those groups? And what do you think are the biggest similarities between those groups?
I think the groups are similar in that they trust me to some degree, but when it comes down to it, I'm not part of either the military community or of their particular cultural community, so there's only so much they're going to open up about. Within those confines, people choose how much to open up, and some people really open up a lot to me. Some people, I am gobsmacked by how much they trust to share with me. They will tell me about things that they've seen in battle and about losing buddies, where that tremendous sense of loss comes from. And in a way, it's like, whoa, I wasn't expecting that. I'm almost knocked over by the power of some of their stories. And the same in the refugee clinic. But this is a part where it's highly variable. Systematically, both groups tend to be lower disclosers. Within those systematic variations, there's individuals who share stories of loss much more. And people they've just floored me with how much they're willing to trust and share. Did that answer your question? Okay, thank you.
Ravensara, thank you very much.
My pleasure. All right, thank you.